Okay, we're now live. Hi, this is Elliot Fishman. Hope you're doing well. It's the 4th of April. It's a Thursday, which means we're about 4 days away from the eclipse. I know the whole world seems to be trying to take off and get into that right path to be able to see the full solar eclipse. I think from Baltimore we may see part. I'm not really sure. Wear your glasses, obviously, if you're going to see the eclipse. If you miss this one, it's not going to be another one for 20 some odd years, but that's okay. You'll see it plenty of times. You'll hear about it. There's a million festivities, glasses being given out, all sorts of hoopla. So that's a good thing, right? There's nothing negative. There's nothing bad about an eclipse. Anyway, you remember when you were a kid, they made those little boxes, and it would shine through a hole in the paper to show so you wouldn't look up, and go blind and all those wonderful things. But anyway, it should be a lot of fun. What else is happening? We're working away. The website, we had to do a whole bunch of security upgrades, which Sarah did a great job on. Anytime you do an upgrade, it's always painful. It's much harder than you think because it's a very large website, and get each part to come back and make sure that everything is working is not trivia, but Sarah took care of that, and we're back in business better than ever, and that should help us not have problems with any viruses or anything bad. So I know it's always a problem for everybody. You saw a few healthcare companies, right? They've been without, they had no one's going to take over our site to get a ransom because there's no money to give you, but it's a big problem in healthcare in general, right? That ransomware, hospitals have been without. Children's Hospital in Chicago, I think for 2 or 3 months, had no medical records. They had nothing. So it's not a trivial problem. It's something that's concerning to all of us because you can think about how problematic it is if you can't look at x-rays, you can't do reports, you can't change anything. It's not just a billing issue. It's an issue of patient safety and patient health and everything else. So it's something that makes the point for companies like Palo Alto, which is a big security company, that those security companies, Snowflake I think is the other one. I don't own shares in those companies, but those are the things very, very important. You need to have high level security, and security needs to constantly be updated because the bad guys are working very hard to be bad guys. So something needs to be done. I also got a haircut. Those of you who said you didn't think I'd be getting a haircut, you were wrong, and I cut it shorter, right? So it's kind of looks super cool. Anyway, this is about the appendix. So let me tell you a little bit about the appendix. The number one reason that we think about the appendix is rule out appendicitis, right? Lower quadrant pain, bowel obstruction occasionally, not a typical GI bleed history, but it's right lower quadrant pain, rule out appendicitis, a common disease in adults, occurs in children, any age group, but the differential diagnosis is large, right? Lower quadrant pain could just be enteritis, and we may do a CT scan and find nothing. In an older patient, it could be a cecal carcinoma, right? So there's a range of things that are in that differential of appendicitis. So let's just maybe think about that. Protocol: if I'm ruling out appendicitis, ideally I always will use IV contrast. That's easy. And scan typically in the venous phase. Gives you all the vessels, gives you a lot of information about bowel enhancement. If you want to give oral contrast, we used to wait 3 hours. Remember the old days? Now you can't wait anywhere near that. So in the old days, we'd give positive contrast, so pacify the ileum, the cecum, and then get a good look at the appendix. Now you really can't do that. You can give water to distend the proximal bowel. That can be very, very helpful. But you can't do the old positive contrast, wait 3 hours. That's long gone for decades, it seems, in most places. So IV contrast is what you need to do. You need thin sections, you need to look at coronals. Sagittals occasionally are helpful. But what do you look for? First, you look for the appendix. Can you see the appendix? Sometimes the patients have had an appendectomy and don't remember, or they had some other surgery where the surgeon took out the appendix. So you got to find the appendix, and we could do this well over 90% of the time if you look careful enough and you really scroll through the data sets, because sometimes the appendix typically hangs down, but sometimes it goes up, it goes retrocecal, it goes many different areas, and it can be somewhat challenging to find the appendix. But let's now make the assumption we find the appendix. And the appendix looks normal, then you want to look very carefully at everything else, right? Is the cecum okay? Is it colitis? Is it a tumor? Is the ileum okay? Is it Crohn's? Is it colitis? Is it enteritis? What exactly are we thinking about? So it's that whole big differential. Occasionally, renal calculi can present with right lower quadrant pain, and the pain is transmitted to the right lower quadrant. Stone is in the ureter, so you want to look at the right kidney especially. Make sure there's not obstruction. Make sure the ureter is not dilated. Make sure there's not a stone in the kidney, the ureter, or even the pelvis. Maybe a stone had just passed perhaps. So you want to look at that. And then when you look at the appendix, you want to think about things. So one thing to think about, of course, is appendicitis. That's what we typically think about. Is the appendix inflamed? Is it thickened? Is there stranding around the appendix? I think, distended appendix, some appendices are bigger than others. If you see air in the appendix, it's supposed to be normal, but you want to look at the appendix carefully. Is the wall thickened? Is there enhancement? Those are both signs of appendicitis. Is there inflammation around the gallbladder? Around the appendix? That's a very good sign of appendicitis as well. With the right clinical history, you are going to be, I won't say you overcall things, but you're not going to just blow things off. You're going to be very, very careful about calling appendicitis. Now, I was looking at some cases recently. We had a case where a patient swallowed a fish bone that got impacted in the appendix, led to a liver abscess and appendicitis. We also remember that the appendix can have other processes, right? So one classic thing is a mucocele, which could be benign or malignant. The appendix dilates. It can rupture. So when it's malignant, we talk about high-grade or low-grade tumors, but you can get a pseudomyxoma peritonei with seeding of the peritoneal cavity from a mucocele. Now, the appendix being dilated can occur in appendicitis as well. So the question is, how can you tell? Well, usually with mucocele, it's more dilated. It's really tubular. Looks like a balloon, a long, elongated balloon. But that's not always the case. I think things that also can be helpful in distinguishing mucocele from appendicitis. With appendicitis, you often have stones in the appendix proper, kind of layering out, kind of like stones in chronic pancreatitis in the duct. With a mucocele, 60% or so have calcifications, but it's in the wall. You typically don't have calcification in the wall of appendicitis, but you have it in the wall of a mucocele. Now, one reason it's important, if you think the patient has a mucocele, you're going to operate on the patient. They're going to be exceedingly careful and maybe do a little wider excision. Now, often if you think it's appendicitis, depending on the patient's history and age and appearance, you might simply watch the patient treat with antibiotics, right? So not everybody gets an appendectomy, but if you're thinking there's a mucocele present, you are going to be doing an appendectomy. So that indeed becomes very important. So it's something you really want to pay a lot of attention to. Mucoceles, if they're removed early, you do fine. Again, once they seed, you have the pseudomyxoma peritonei, and you need extensive surgery and chemotherapy to treat that. What else in appendicitis can simulate it? Things like salmonella can involve the terminal ileum, so infectious processes. Things like TB can involve the terminal ileum, the cecum, and also involve the appendix. TB is pretty rare, so involving the appendix is pretty rare as well. We have seen cases of diverticular disease of the appendix, but then again, that's appendicitis, and so you can call it whatever you want and be more accurate, but out it comes. So one of the key things, of course, is the management of the patient, right? So we say appendicitis most of the time in most places, the patient will get an appendectomy. And you want to make certain when the pathology comes back, it says appendicitis. So we need to be very careful. I think sometimes it's tricky. Sometimes patients with poor tissue planes, it's hard to find the appendix. Well, you see the appendix, and is it just compressed, or is it a little prominent? Is there a little stranding nearby? I want to make the point that it's not always simple to say a patient has appendicitis. In terms of pregnant patients, that question always comes up. We're typically still doing CT. A lot of people are switching over, and we will also to MR. Though MR is tricky, right? You know, you're looking for a very small structure, obviously less radiation dose, but you need to have a lot of experience. If not, you're going to have problems and miss appendicitis. And in a pregnant patient, the last thing you want to do is miss appendicitis or overcall appendicitis. So it becomes a little bit tricky. So those of you who don't have a lot of experience with MR, doing CT for appendicitis in a pregnant patient is definitely the right thing to do. I think there's no issue about that. And again, you don't need to scan the entire abdomen, pelvis, limit the area, lower the dose, but still you're going to get a great study and you should be able to make the correct diagnosis. So that's really it for appendicitis. If you go to the website, we have a lot of cases. I am putting together, because I gave a conference yesterday and I showed a bunch of appendicitises and mucocele, so I'm putting that all together. I did a literature review and I'm going to try to make that into a talk, so you'll see that over the next couple months. Now let me see, we got a lot of people saying hello. We have Hassan from Norway and Kate Cook, I'm not sure where. John Biacchino, one of our senior techs, is home today. Nayanda Felix is saying hi. Shalova Maya is in Kurdistan. And Usan. Praveen is from Nepal. And Zusin, excuse me, is from Somalia. So, wow, this is, it does make the point about why the web is so good. And Anne is from the Philippines. Just think about, I've spoken now for about 12 minutes, and Vishavalov is from Slovenia, and Sayed is from Qatar. It does make the point about education being global, and we take great pride in CTisus that so many people from so many places do follow us, and we do try our best to make sure that we meet your needs. So again, we always like to say, any questions, you can put it down, I'll try to answer. Any suggestions for these Thursday talks or lectures or anything else, just let us know, and between Lily and myself and Sarah, we'll figure out what I need to do. Anyway, Zakir from Pakistan, so a United Nations we have here. So I appreciate everybody, and hope everybody has a great day. Thanks a lot.